Good evening, everyone. It's about that time. We're about to get started. Welcome everyone to I think this would be our last meeting until we break for summer. So I'm happy to see everybody who's on today. And we will just get started with a word of prayer, if we may. Heavenly Father, we ask for your guidance and wisdom as we gather today. May our hearts be open to listen and our minds be clear to communicate. Fill us with your grace, Lord God, and continue to remind us that all we do for the Cancer Society and all that we accomplish is for the service of humanity. In your name we pray. Amen. Welcome once again, and thank you for joining us this month. Before we get started, well, I guess we have gotten started. So we will begin with any celebrations, birthdays, anniversaries, milestones. If anyone has any of those they'd like to recognize, feel free to share with us. Let us know what you're celebrating, birthday, anniversary, milestone, or anything else. Let us know. You can open your mics or you can put it in the chat and we'll read it out for you, either way. No celebrations? Or no celebrations since we last met? Okay, well, if you don't get to put it in now, you can put it in the chat and or we can do it at the end of the session. I'm gonna ask Erin now to give us the announcements, please.
Good evening, everyone, and welcome once again. Well, no one had no birthdays. There's probably a new crew here.
Yes.
But welcome anyway. All right, well, we're just coming off of our ball, our royal ball. So if those who had attended, I hope you had a royal time. Unfortunately, I was not able to attend this year, but I'm looking forward to next year because I heard and I've seen pictures that the ball was fantabulous. It was really a royal experience. Well, on to our notices. Well, I want to introduce, I hope she's on right now, but we have a new member of our staff, Kristen Duncan, and she will be moving forward, helping us with announcements. So if you see an unfamiliar face, that will be Kristen. If you're on, say hi. But she will be helping us out with announcements moving forward. We have a virtual support group meeting that is on every second and fourth Thursday of the month, but we're going to have one tomorrow, saying that it's a short week. So we're going to have a virtual meeting. Look out for our newsletter. We will send the link. Whoever wants to join the meeting, whether it be a survivor, someone still going through treatment, or even a caregiver, because this support is for everyone that has been affected by cancer, whether it's a family member, a coworker, or friend. But we want to show support and to listen to those who needs to be voiced. Also, we have our FIMS, which is our Family Island Mammogram Screening. And this is where we bring a maximum of 15 ladies from the Family Island here to Nassau to have mammogram screening. And last month, we had ladies from Cat Island. And so next Saturday, we will have 15 ladies coming from North Andros. We partner with Oak Tree Medical, who assist us with conducting the mammogram screening. We also have our free clinics. Our free clinics is where we go to the Family Island on a monthly basis and do free pap smears and PSA. And this will be conducted on Cat Island. So Cat Island has been back to back with screenings. And you know, the Cancer Society vision is to detect early. Monthly meeting, like our president had mentioned, will be the last monthly meeting with a presenter. We will be breaking for the summer. and we will resume back in September. So that's it for our announcement. There's not much going on. Oh, another plug in there. Usually for the summer, for the support group, we have a summer survivorship social. That's where we have events here at the Cancer Society. And again, it's open to those diagnosed with cancer, those who have survived, and also caregivers and the family. And we have fun nights such as karaoke, bingo, spin the wheel. So it's an event for anyone that has been a caregiver or has been affected by cancer to come and just have a fun night. So look out for the dates and look out for the events that we will be hosting. So without further ado, I will pass it on to Madam President.
Thank you, Erin. Thanks for those announcements. And yes, those of you who missed the ball, you really did miss a royal affair. It was awesome. So now we turn to our speaker, and as you know, our focus this month is melanoma and skin cancer awareness. So I would like to, before I begin the bio, I want to put out a disclaimer that I am very challenged with our speaker's name. I did a Google search on how to pronounce it. So Dr. Srikanth, if I'm not pronouncing it correctly, then blame Google, don't blame me.
You did very well. Srikanth Garikaparthi.
There you go. I think that's how Google said it, actually. So, wow. Yeah. So, Dr. Garikaparthi works as a consultant plastic surgeon at the Princess Margaret Hospital, Nassau, Bahamas, since August 1999. He did his training in India and received his MBBS degree from Osmania Medical College, Hyderabad, sorry, in 1990. He went on to complete his residency in general surgery and fellowship in plastic surgery. He went to do additional training in hand and microvascular surgery and worked for a short period as an assistant professor in the plastic surgery unit at Osmania General Hospital, Hyderabad, India. He also obtained his fellowship from the Royal College of Surgeons in Edinburgh. For the initial nine years, Dr. Srikanth, as he's known in the Bahamas, because, you know, we challenge with that last name, in addition to plastic surgery, covered trauma and a general surgery at PMH. Subsequently, plastic surgery became an independent unit covering plastic, hand, burns, and wound care. Dealing with skin cancers at the hospital led him to pursue specialized MOHS training. Since 2010, he has dealt with 600 plus skin cancers in both public and private practice. He loves teaching, and since 2002 is the lecturer of the MBBS surgery program at the University of West Indies School of Clinical Medicine and Research, Nassau, Bahamas. He also established the DM Postgraduate General Surgery program in 2005 and led it until 2014. He was also the tutor for the postgraduate family practice and accident and emergency programs. He is now part of the DM plastic surgery program at the University of West Indies at Jamaica. He is a member of multiple professional organizations, including the Association of Plastic Surgeons of India, American Society of Plastic Surgery, International Association of Aesthetic Plastic Surgeons, International Plastic and Reconstructive Surgeons, American College of Surgeons, and the Medical Association of the Bahamas. So with all of that said, over to you, Dr. Srikanth.
Thank you, Ms. Wilkinson, for this kind introduction. I have control and I'm going to share my screen. And here we go. Everybody can see my screen?
Yes.
Great. So at the outset, let me thank the Cancer Society of the Bahamas for an amazing and outstanding job that you all do. You volunteer your time, energy, and I'm pretty sure expenses, and you've been taking care of the Bahamian public in an exemplary fashion. I wish there were many more organizations like you in our country. I also want to thank Dr. Williamson Shea for calling upon me to do this presentation. And it's an honor for me to be part of this public speaking engagement. So without further ado, let's dive into this presentation. Now, I looked at our own website, and I found a nice little article about the presence of the. Okay, where's my screen on? Sorry. No. 1 minute. I lost my screen share. Okay, got it back. All right, so I found this little brochure on the website that pretty much covered in full focus about what we talk about skin cancers. Why do skin cancers matter? You know, the Bahamian way, where we project ourselves as sun, sand, and water for all the tourists to come here and enjoy. But for us, it comes with a hidden cost. Globally, the incidence of skin cancers is rising, and it is mainly due to the solar ultraviolet radiation. You can blame on the thinning of the ozone layer, but it's the major risk factor. Skin cancers are approximately 5% of all cancers that are diagnosed in the human body. But fortunately, skin cancer deaths are only 1.4% of all cancer deaths. And I will touch upon this top point later on. Skin cancers are very common in the elderly, in the males, and in Caucasians with chronic ultraviolet exposure. In people of color, it is often diagnosed later, and we all know that a late diagnosis of cancer makes it much more difficult and harder to treat. Why melanoma in particular? Among all the skin cancers, 98% of the deaths are due to melanoma. Number two, it just does not develop in the skin, but it can develop also within the eyes, the scalp, under the nails, on the feet, inside the mouth, the oral cavity, and in the anal canal, where there is a little bit of skin. The lifetime risk for developing melanoma in Caucasians is 1 in 40. In Hispanics, goes down to 1 in 200. And in population of African origin, it's 1 in 1,000. So contrary to the myth that darker pigment skin population does not have skin cancers, we are affected with skin cancers. And the problem in people of color is that melanoma appears in areas that are not exposed to the sun, like the palms of the hand, the soles of the feet, or under the nails. Another disturbing factor is that for people under the age of 30, the rate of melanoma is increasing faster than any other demographic group of cancer. And it has increased by 50% in women since the 1980s. Look at this map of the world and the highlighted areas. In the right-hand corner bottom is the Australia and New Zealand with one of the highest incidences of skin cancers. The next biggest group is in the Nordic countries, Norway, Sweden, and Denmark. These populations have the highest incidence of skin cancers, but the total volume of skin cancers, total burden of skin cancer is highest in the United States because of its large population size. We need to talk about the types of skin cancer. Obviously, today we are talking about melanoma, which arises from the melanocytes, which are the pigment cells that are found within the skin. But we also have what is known as the non-melanomatous skin cancers, mainly the squamous cells that arise from the top layers of the skin and basal cells that arise from the bottom layer of the skin. And these are the three main cancer types. There are so many other skin cancers, but they're very rare. Look at this chart. The pink, which is covering 80% of the total number of skin cancers, is basal cell cancers. And we are very glad that this is the number that states that even though cancers are not a good diagnosis, I'm glad that 80% of the skin cancers are basal cells. The next highest, 16%, is squamous cell, and melanomas are only 4%, and less than 1% of the other rare varieties. Now, who are at risk for these skin cancers? Individuals with a family history of skin cancer, because there might be some genetic traits. Individuals with albinism, they don't have any pigment in their skin, and these patients develop multiple types of skin cancers, and they develop them quite early in their age. Individuals with numerous moles increase the risk of skin cancers, and people with prolonged sun exposure, and that is where Bahamas comes in. Key facts about sunburn. This is a very important factor. One, blistering sunburn in childhood, where a child will go out, play, come back with blisters, doubles the lifetime risk of developing melanoma. If you had 5 or more blistering sunburns before the age of 20, your melanoma risk increases by 80%. And the risk of non-melanoma cancers goes up to 3 times. All these from sunburns before the age of 20. But more interestingly, intermittent intense sun exposure, like we go on a vacation and you get burnt, is more dangerous than chronic exposure because it gives time for the malformations that happen within the skin to continue. Now, we might have many, many things that happen on our skin. We all look at it on a daily basis. Many things happen. We can develop acne. As we grow older, we develop some skin tags. We develop some prickly patches, some pigmentary changes. We have skin changes that are freckles. We have these little tiny blood vessels, the cherry angiomas that happen, or we can have moles. But what we need to look out is for the cancerous lesions, the basal cell carcinoma, the squamous cell, or the melanoma. What do we mean by that? So there can be many number of primary lesions, like a patch, a raised little bump, or a little bigger swelling that we are worried about. But more worrisome should be when you have a crusting of that lesion, when you are itchy over the lesion, or when there is a crack or an ulcer that develops from these lesions. Those are the secondary changes that we need to be worried about. Let's look at this patient's picture in the left upper corner right here. Look at right in this small area, this patient has a multitude of lesions, some pigmented, some non-pigmented, a little raised lumps. Majority of these are present for a very long time and are benign. They are not serious. This lesion that is right in front of the ear has been rapidly evolving. And if you look a little bit more closer, and you would notice the changes, the edges that are not irregular, and that makes it a little bit more worrisome. Similarly, this patient in the middle with a leg moles, you see 2 moles. One much lighter, well-defined, has been there for a very long period of time. Whereas this mole much further down is much larger, is a little bit more irregular, and has a little bit more color changes on the higher magnification. You can see the different color changes. That's worrisome. So what do we do? How do we think about cancers? There's the ABCDs of melanoma. What do you mean by that? The ABDs are when a lesion is not symmetrical, it is asymmetrical. So this is a symmetrical lesion, this is asymmetrical. The B, when the border is regular, but on this side, the border is very irregular. The color is uniform in a benign lesion, but it is changing, it is different, it is evolving. And D, the diameter, generally, if it is less than 6 millimeters, it's more benign. But the minute it starts to increase beyond 6 to 7 millimeters, we start to get worried about it. And then the final thing that is very important is evolving. It is not staying the same. It was there, then it started to grow, it started to itch, it started to ulcerate. The other interesting thing that you need to look for among the moles is the ugly duckling sign. Look at these ducks. Look at these baby ducks. They're all looking similar except this one. We might just look at it and say, wow, looks nice, looks beautiful. But that's not what we're looking. We're looking one that stands out from the rest of the other moles. It is much more darker or bigger, or one that is lighter in the middle, or one that is all by itself. It just arises and it is not there in place where there were multiple moles. That's the ugly duck that we need to look out for. That's the mole that we're worried about. What do we need to do? We need to immediately consult a specialist who deals with skin. Dermatologists are usually the best people, but family medicine specialists are also important because they get good training in dermatology. And there are some family medicine specialists within the Bahamas who actually subspecialize in dermatology. They do utilize a dermoscope, which is a hand illuminated instrument. It is non-invasive. It doesn't put needles or anything into the patient's skin. It magnifies 10 times. So once they put it close to the skin, they can actually see 10 times better. And it can actually help classifying to the physician the lesion that they're looking, whether it is benign, that is, whether it is cancerous or not. If it is benign, that is not to be worried about. All you need is a careful follow-up. But whereas when it is a sinister lesion, when there is something suspicious, we need to biopsy. Who does the biopsy? Any of the physicians can do these biopsies. What do you mean by a biopsy? We take a piece of what we are looking at to confirm under microscope, send it to a lab where the pathologist looks at it, and that is the ultimate different diagnosis. So anytime we have a suspicion and we are not comfortable, either the patient or the physician, the biopsy is a proven method of making the diagnosis. Now, sometimes physicians can dismiss and say, don't worry about it, you can do a telephonic consult. But if the patient feels there's something wrong, biopsy has to be done. What can we do? We can do a straightforward shave biopsy with a simple blade. We numb the area and we shave it. And it's a good type of biopsy for a lot of skin cancers, not particularly good for melanomas. We prefer a punch biopsy where you take a little punch and go through the whole thickness, and I'll tell you why, that this is an important form of biopsy for melanoma. We can also do an incisional biopsy. That means when you have a large lesion, you want to take a part of the lesion and also a part of this normal skin for comparison. Or sometimes, if the lesion is small and we don't really think it's a melanoma, or we think it is a basal or a squamous cell carcinoma, you can do what is known as excisional biopsy. That means you can cut it out one time if you can close it safely and send it for the lab. You just put it in a bottle with formalin and ship it to the lab, where the lab is now going to process it and the pathologist will send back to us the report. When the surgeon or the physician gets the report back, they have to call the patient. It can be a telephonic consult, but I always tell my patients, if the diagnosis is something a little bit more scary, like a melanoma, I would rather have the patient sitting in front of me face to face to have this discussion. Kind of feels impersonal to call them on the phone and give them a very, very sad news. Once the diagnosis is made, we can then discuss about what is the next step. And one of the next steps, whenever a diagnosis of cancer is made, is to start staging the cancer. We need to know, where does this tumor spread? Where is it gone to? So we have tools at our disposal. The main tools are non-invasive. You can do a CT scan, an MRI, or a PET scan. The physician also has to look at all the other general health parameters that the patient is suffering or going through that will allow us to treat these patients properly. Melanoma staging. One of the more important things with melanoma that is very important, look at the bottom, is that we look at the tumor thickness. So when you look at the skin, as the melanoma is going down, invading deeply, we start measuring its thickness. Is it 1 millimeter, 1 to 2, 2 to 4, or more than 4? This is the most important prognostic factor. For example, if you take breast cancer and you talk about breast, the size of the tumor is important, less than 2 centimeters, 2 to 5, more than 5. In melanoma, the thickness of the tumor, how thick it is involved, the skin, is the most important factor. And that is what we do. That's why I said the punch biopsy is very important to diagnose melanoma, because it's just not important to diagnose that the patient has melanoma, but we also need to know how thick is the tumor. And then whether it has spread to the lymph nodes or whether it has spread to the liver, lungs, or brain, or to the bone, because that means the tumor is way far advanced. The treatment of melanoma primarily is surgery, and the goal is to remove all of the cancer with clear margins. We have a margin. So if the tumor in the center, if it's in situ, that means it has not breached the basement membrane, the margin is only 0.5 centimeter. But if the tumor is 1 millimeter or 1 to 2 millimeter, you start having to take a centimeter of normal skin around it. And as the thickness increases beyond 2 millimeter, we have to go and cut 2 centimeters. So even though the tumor is here, you have to take out all of these, because melanoma has this very sinister way of spreading by individual cells into the normal skin. So if you miss even one cell, that is a death sentence to the patient. So the recommended margins are very great in melanoma. To give you an idea, this center on the left-hand side is the tumor. There is a little bit of discoloration all around this. And that inner margin that I marked around is what I think to my naked eye where the melanoma spot is on this foot. And I then marked out 2 centimeters beyond and look at where this initial margin is and where I'm cutting this entire sole. Similarly, look at these two bottom pictures, and the top picture is what I've cut out. That whole area that I marked out, and you see I've gone right along the margins, and I put all my markers to know exactly where, and I'm going to sending it to the lab. Look at this foot that I picked it off the internet. This is an acrolentiginous melanoma, a dark spot, but a lot of area that appears to be. They have marked only 1 centimeter. I would actually be doing a larger one on this one. This one is similar. Look at the lesion and look at the 2 centimeter margin that has been put around this. So melanoma surgery is a little bit more destructive. We don't really think about cosmesis. We don't think about functionality. We want to get rid of the cancer and then think about other things. And this is why it is important. Look at the prognosis. If it is in situ melanoma, there is 100% survival if you've done proper surgery. If it is stage 1, it is less than 2 millimeters and there are no nodes involvement, a 5-year survival is between 90 to 95%. Stage 2, when it is more than 2, it starts dropping down. The minute it spreads to lymph nodes, it drops down dramatically to 40%. And if there are distant metastases, this used to be 5%. Of late, it has gone up to 15 to 30%, and that is because of immune therapy that we have access to nowadays. So these are the game changers that have come about in melanoma. But look at, before I go on, the cost of these treatments are just not available to each and every person. It costs anywhere between $150,000 to $300,000 per annum. And what are those things that we usually use? It is immunotherapy. Immunotherapy is the game changer and is exclusively used for stage 3 and 4 cancers. There are multiple drugs that are being used and are being researched. You also have targeted therapy because a lot of melanoma have these chromosomal abnormalities. and therefore respond to this treatment. You also have a viral treatment where you have modified herpes virus that is injected into these patients. There is radiation treatment, but that is only for brain mets or for palliation. And there are multiple clinical trials. We can try and enroll into these trials, but again, we might not be lucky because we should have access to them. Having dealt with melanoma, I just want to bring some focus onto the non-melanoma skin cancers too. I apologize for the busy slide. I didn't want to put in too many slides. I just want to talk about basal cell cancer, the 80% of these cancers of the skin. I just want you to concentrate on the center of the slide. This cancer grows very slowly and does not spread at all. In fact, I should say rarely. And people do come to our clinics, come to the radiologist and dermatologist clinic and say, I have this spot that seems bothering me, but it heals every few weeks and then comes back. That's a classical sign of basal cell cancer. Don't leave it too long for it, because I can show you where, especially if it is on the face or on the skull, it can go deep into the brain or can eat into the patient's face and can cause death by bleeding. The other 15% of skin cancers among the non-melanoma skin cancers are squamous cell cancers. Now, these are a little bit more dangerous. They can grow faster and they can spread, especially on the face, especially if it is on the lip, the ear, or if it is in the genital area. And because it can spread, there is a risk of death with these cancers. The primary treatment of both these cancers is surgical excision, like we do an excision. But the excision of these cancers is a little different. And one of the common things we do is called Mohs surgery. Now, that is what in my introduction I did mention that I did training in this Mohs surgery. Now, why is this surgery a little different? In Mohs surgery, we actually take a very small margin around the skin cancer. So the inner dots is what I think is where the edge of the cancer is, and I actually cut it out. And we can do this only in basal and squamous cell with these small margins. We do this surgery, we cut it out, stage 1. We immediately test for pathology. We don't put it in the container. We don't send it to the lab. The lab is within the office. We immediately check for the margins. You see these little cuts here and there we say, okay, this is how we're going to check it out. Once we know that the cancer is clear on all sides, but the cancer is present on the top side, we go back and cut again and cut again. So this is called Mohs surgery. Why do we do this, especially on the face? Because we hardly have much excess skin on the face, nose, ears, lips, and we want to save this. It's a little bit more costly, it's a bit more expensive, but this is what is needed if we are to do this kind of complicated surgery in the non-melanoma skin cancers. We don't apply Mohs surgery, at least I personally do not apply Mohs surgery to melanoma, because we want to get rid of as much as normal skin around the melanoma. So that these are the multiple steps in the Mohs surgery, just a runny, busy slide where we cut it, we stain it, we run it through the machine, we read the slides immediately, and then we decide whether we need to cut back or not. There are non-surgical treatments for non-melanoma skin cancers. We can use topical ointments, 5-fluorouracil imiquid, or we can use a cryo, the liquid nitrogen, to freeze these. But these are very specific. For precancerous lesions, the sun-damaged spots, superficial basal cell or superficial squamous cell carcinoma. We might use radiotherapy for elderly patients who are not fit for surgery, or for advanced cases. Chemoimmunotherapy is only for squamous cell carcinomas that have been advanced. One such picture of a patient with an advanced basal cell cancer that he just decided to leave it long, went through the nose, destroyed his nose. We could treat that effectively with radiation therapy. I don't know whether we can achieve cure, but at least we can control, and then we can add surgery to this and then reconstruct and still achieve reasonable results. So this is one of the things with skin cancers. And you look at the prognosis of non-melanoma skin cancers. BCC, we don't typically stage, and their 5-year survival is more than 95%. In my practice, I would say it is close to 98%. Squamous cell, earlier, you get about 80 to 90%. Late stages where it has spread to lymph nodes, the survival rate drops. If it is on the limbs, we have done amputations, but we would rather not see these advanced stages. Prevention. Prevention is the cure. Prevention is the name of the game when it comes to cancer. Few things that were very popular in the past, they're still popular in a lot of Nordic countries, is the tanning beds and lamps. You should avoid them completely. They are classified as grade 2, grade 3 devices by the medical FDA and European Union. You should definitely limit exposure between the morning hours of 10 to 4 p.m., the midday afternoon. Become very familiar with your skin. Regularly examine your skin, the front and back, the soles, the scalp, the nails, and including the private areas. Wear protective clothing, the UV light protective clothing, and a broad brimmed hat, not the baseball hat. It doesn't protect your back of your head or your back. Put on sunglasses that are both can filter out the UVA and UVB rays. Wear sunscreen year round, not even on cloudy days, because even on cloudy days, we are exposed to UV radiation. Apply sunscreen generously. Generously means an ounce, 30 ml, a shot glass worth of sunscreen for your body, and reapply it half an hour before you get out in the sun, and reapply every 2 hours or more often. If you get into water, you're sweating. Now, as we Bahamians say, when we go for something interesting or for a dinner, we have to tote. What do we tote from this lecture? We have to avoid sunburns right from childhood. So taking care of children, putting effective clothing is very important. Seek medical advice for any skin lesion that doesn't heal within 3 weeks. An itchy spot, a cut or a bruise that we treat effectively. We don't scratch, we don't itch, but we put effectively Vaseline, sun lotion, but it doesn't heal. Go get it checked out by a medical person. Early diagnosis and treatment is the key, and surgery is curative and performed for early disease. With that, I come to my presentation. I once again thank the Cancer Society of the Bahamas for inviting me to give this lecture, and I'm open to answer any questions or suggestions or comments. Thank you.
Thank you very much, Dr. Srikanth. If anyone has any questions, comments, feel free to open your mics and you can either ask them, or if you don't have audio, then you can put them in the chat and we will read them for you.
I have a question. Good night, Dr. Garikaparthi. How are you?
Hey, Gina.
Good. Quick question. I know a lot of Bahamians, dark skin in particular, do a lot of skin bleaching. And that takes top layers, 2-3 layers. I'm sure that's just as dangerous as sunburn. Am I correct?
Absolutely. You're basically damaging the skin, and you're causing the skin to thin out, and that does cause its own particular problems as they keep going forward. And we are seeing more and more skin cancers. Now, I can't really say exactly what is to be incriminated, but yeah, anything and everything is a possibility.
Oh, I have one other question also. I know that the sun is really dangerous, but I noticed that a lot of the cancers that you showed were bottom of the feet, in the hands and whatnot. What can we do to prevent those types of cancer? I mean, that's not sun related. What other things is it that we need to be aware of?
What I showed you, the melanomas generally, especially in the darker pigment population, definitely happens in the foot and the palms of the toe. You can't really protect anything. You have to basically be watching those areas. That is something. But you do protect your general protection when you go out in the sun. You cover yourself as much as you can, and avoid the direct sunlight in the middle of the day, especially when it is really bright and hot.
Thank you.
Any other questions, comments? I will just put a comment that it's amazing to hear your presentation because I guess if you go out on the beach, you see people lying out on the beach applying oils, trying to get a tan, or people out in the boat. I think there's a little bit more consciousness of it now, but people are still, for the greatest part, still exposing themselves very much to the sun. I guess tanning, we call it, but I guess it's really something to watch out for, and spread the word that that's not a good practice. And I'm happy to hear you say that the tanning beds, I think they should just eliminate them altogether. But anyway, I guess that's a choice.
Yeah, I mean, it's amazing. I mean, literally over the 25 years that I have lived here, that I've been practicing, the incidence of skin cancer is just increasing every day. I used to see them every now and then. Now I see them almost. I turn around in my private practice at the hospital. We just see these cases coming by the plethora. And I know a lot of these patients, in fact, a lot of them who can afford are going away too. So
Mhm.
we do have a very high burden. Now, yes, it might not be a significant public health problem, but it is definitely adding a lot of morbidity and a lot of weight to already our crumbling health infrastructure.
Yes. And another comment, I guess, on the those I guess skin and flesh, those fleshy moles. Should we be concerned about those, the incidence of those occurring?
Not really. They are benign lesions, and just a lot of them get treated for cosmetic reasons. But again, as I say, anything that has been there on your body that starts to change its behavior, it was there forever, or it's now beginning to show some changes, please get that checked out. That's the only way. And we cannot diagnose them without a biopsy. A lot of times we can look at it and say, okay, this looks benign. But if the patient is concerned, if the physician is concerned, the only way to deal with them is a biopsy.
Okay, so I'm checking the chat. I don't think I see any questions. Lots of comments, very informative and timely presentation. Thank you, Dr. Srikanth. Very informative. Really enjoyed your presentation. Very informative, interesting, and informative talk. So that's the general feedback. And I share those comments as well. It is very informative and I guess eye-opening in a lot of ways as well. Things we kind of took for granted, things you need to be more aware of, and that's why we have these presentations. So thank you very much.
Thank you.
For attending today. Does anyone else have any other questions, comments? Okay, so we're still on time. But yes, Dr. Srikanth, thank you so much. And if anyone wants to get in touch with you, where can they find you?
I'm at the hospital, Princess Margaret Hospital, and the plastic surgery clinic. Anyone is more than come to make an appointment. I also have a practice right opposite the Cancer Society in the Health Facilities Building. So that's my office, Bahamas Surgical Associate Center. But as I say, a lot of dermatologists, family medicine specialists are my frontline people. I am almost at the top of the food chain, as they call the pyramid. I get a lot of referrals from a lot of my physicians who do a great job, who diagnose, who do biopsies. And I feel that skin cancer diagnosis is something that is not to be specific or specialized by one person or one physician. Everybody should be able to, like any cancer, because that's the oath that we all take as a regular physician, that we will take care of patients. Prevention is the name of the game, and healthy living and healthy lifestyles is the motto that we need to preach and practice.
Yes, very much so. Yes. Another comment, let me see. Yes, let me see. Okay, I think let me see. Thank you, Dr. Srikanth. I really appreciate you taking the time to do this. I don't have any of those spots, but I do have discoloration on my feet that is very concerning to me. That is a comment from somebody. I don't know if
Yeah,
you.
we should definitely look at it and see what exactly is happening. And remember now, skin is a very large organ, and it is reflective of your overall general health. Okay, so not only it is getting affected by environmental reasons, it is also going to get affected by what is happening within your body, and how your general health is, what are the general illnesses that you might have. If you're diabetic, your high blood pressure, you have hypercholesteremia, all of these things manifest within the skin. So, and it's a common thing, right? People look at a patient's face and can say, you look good, you look well, you look sick. And that's a reflection of our internal milieu. So please get it checked out by your family physician, and let them make a concerted effort at evaluating your overall health in addition to whatever your concerns are.
All right, thank you for that. She also added that she's a type 2 diabetic.
There you go. I knew that was coming in. So yes, please get that evaluated, check it out. Type 2 diabetics have peripheral neuropathy, and a lot of discoloration, a lot of these things starts off with your neuropathy, and we need to basically evaluate all of it.
Mhm. Okay. So, another question. Thank you again for another wonderful presentation. Okay. So, if there are no other questions, comments, we will thank you once again, Dr. Garikaparthi, for your your wonderful presentation. As we head into summer, it's, I'm sure, very timely. So remember your sunscreen, everyone. Remember your broad brim hats. Remember your UV clothing. Forget those skimpy bikinis. Cover up, cover up, cover up. And stay healthy. Remember, what you put in makes a difference. What comes out, healthy lifestyles and all of that. So thank you very much for the presentation. Thank you all for attending today. We had a good sized crowd. I'm glad to see that. And we'll be back. When will we be back, Erin? September?
Yes, the second Tuesday in September, which will be September 9th, we will be back. And also too, for those that want to share this presentation with friends, it's on our YouTube link. You can either go to our website, it will publish tomorrow on our website under news, and you can share it with family and friends, because as Dr. Srikanth says, these molds and discoloration, and we believe that we are dark skinned, that we are exempt from skin cancer. And being dark skinned too, we probably won't detect it early enough. So yes, we have to really let our family, friends, and loved ones know that even though we're dark skinned, we still have to protect ourselves.
Yeah, for
So-
some reason, dark skinned people typically say they don't need sunblock or they don't need sunscreen, but everybody needs it. It's
Yeah.
the message.
Absolutely. Especially those guys that work out in the sun all day, and they're not protected.
Those golfers, those other people playing outdoor sports. Yes. Word to the wise.
Oh, somebody
thank-
just, any tips for kids and hosts of summer camps?
Avoid, we already said that 10 to 4 period, they should not be outdoor. And they better be covered very well, protected with clothing. And I know it's going to be, it sounds contrarian, you're hot, but you still have to cover. But a lot of new clothing is available now that is light, breathable, but at the same time it protects from UV radiation. And I think that is what we need to. And I think I've seen the younger generation, the younger parents are a little bit more in tune to these things nowadays. But again, it's a matter of availability, economics. But I'm glad that these things are available. So if they're available and they're affordable, you should use them.
Mhm.
Yes.
Yeah, I noticed a lot of the swimsuits now come with like a long sleeve type,
Yep.
top.
Yes.
So
Rash
particularly
guards.
for kids, rash guards, yes.
And they're very light, Dr. Srikanth, and breathable. So you wear them and you don't feel hot and sweaty,
No.
So
Yeah.
encourage more persons to wear them, especially this is the summertime and everybody wants to do more beaching because indoors is hot. So they want to be outdoors. So
Mhm.
protect yourself, protect yourself, protect yourself.
That's the message. So yes, so thank you. So that will end our meeting for tonight unless anyone has anything else they'd like to share. Otherwise, we'll end here and we will see all of you hopefully again in September when we come back. So enjoy your summer holiday, enjoy the break, and make sure you protect yourself during the summer months in that heat because it's already shaping up to be a very hot one.
Yes.
So, okay then. So good night, everyone, and stay safe.
Good night.